Yes, Anand. Slides are visible. Slides are visible.
Yes, sir. Slides are visual. Sir.
Moving. Slides are moving now.
Yes, sir. Yes, sir.
Hello,
Yes, sir.
welcome Dr. S.S. Dariya.
Thank you, sir.
Uh, this ICP masterclass on hematology is proud to have you here.
Thank
And
you, sir, for inviting me.
you can very well see the print of Jaipur well engraved on my heart.
Thank you, brother. Thank you.
Uh, so today, I think your topic is megaloblastic anemia, right?
Yes, sir. Yes, sir.
And
Tiwari sir is here or not?
Dr. Tiwari will not join. Dr. Sanjay will join. And mm, Dr.
Let me call Mehta, sir.
Dr. Mehta will join. No,
Yes,
we have to stick to the time because
definitely.
you have a long lecture to take.
No, no, no. I'll finish. Amit, sir.
Hello. Yes.
Mehta, sir will join in next few minutes. He
Okay.
asked, you can start.
Okay. So can I start the proceedings without wasting much time?
No, no. Is Dr. Sanjay is coming?
Dr. Sanjay will join in a minute.
Okay.
Yeah. Uh, dear friends and colleagues, uh, let me welcome you to another class of ICP Masterclass Hematology. Under the guidance of Dr. Sudhir Mehta, today's session will be taken by none other than Dr. Ser Singh Daria, who is an assistant professor at NIMS Jaipur, and he is a personality larger than life. He is a governing body member of National API, National CCDSI, and National IACM. He is holding multiple posts in API, CCDSM, and IACM. His academic excellence is known to everyone, and he has achieved multiple awards and has more than 40 national and international papers. Dr. Dariya is a keen learner and a keen observer. He has great skills and he is a master teacher as well. So, welcome, Dr. Ser Singh Dariya, for a wonderful class on megaloblastic anemia. And you all know that megaloblast means large sized, and we have a larger than life personality, Dr. Dariya, talking on megaloblastic anemia. Welcome, Dr. Dariya, and over this session belongs to you from here on.
Thank you so much, my elder brother, Dr. Amit Das from Muzaffarpur, Bihar. And at the outset, I would like to thank our course director, Dr. Sudhir Mehta, sir, for inviting me here. So we'll discuss something about the megaloblastic, third in the series, fourth in the series. Last week, Dr. Amit was there in Pulse in iron deficiency anemia. So now move on to the megaloblastic anemia. We all know that what is anemia, it's a decrease in hemoglobin level, but what the megaloblastic anemia as defined, there is an impaired DNA synthesis. Because of that, there is an ineffective hematopoiesis and restrictive morphological changes. So both either the large erythroid precursor or itself the red cells. Uh, for defining any anemia, we should see the mean corpuscular volume. So at the base of MCV, you can classify into the micro, macro, and the normocytic anemia. And this megaloblastic comes under the macrocytic anemia. The slide may not be visibly good, but at the base of MCV, the anemia divided into three, the micro, macro, normocytic. If the MCV is less than 80 femtoliter, it is microcytic anemia. If it is more than 100 femtoliter, then it is a macrocytic anemia. And between normal 80 to 100 femtoliter, it is a normocytic. So we have to see once the MCV, if it is more than 100, then look at the peripheral blood film. If there is a hypersegmented neutrophils, think about the vitamin B12 and folate deficiency. If there is a no hypersegmented neutrophils, think about the polycythemia or target cells. In target cells, the liver disease or increased liver enzyme may be the reason for that. And if polychromasia is present, then reticulocytosis is the answer. Then again, further for the reticulocytosis, you should go for a LDS, bilirubin, and haptoglobin to find out the reticulocytosis. Request to everybody, please mute yourself. We'll discuss after the completion of.
Sir, you are muted. सर आप म्यूट हैं सर आप म्यूट हैं
Why it's happening again and again? So the non-megaloblastic causes of the macrocytic anemia, we have to see the retic count. If retic count is increased, it may be because of hemorrhage, hemolysis. If retics are decreased because of some chronic liver disease, hypothyroidism, alcoholism may be the another cause, and if bone marrow failure in case of aplastic and the MDSN. 95% etiology of megaloblastic because of the B12 and the folate deficiency, but yes, 5% reasons are because of anti-metabolic drugs like methotrexate, the inborn errors of metabolism, the refractory anemias, and the erythroleukemia. Why there is a vitamin B12 deficiency occurs in the body? It may be because of either the decreased intake, because of inadequate diet, or in vegetarian people, due to because of absorption problem. If absorption is impaired, it may be because of IF factor deficiency, intrinsic factor, which is necessary. If it is a deficiency, then we used to call it as a pernicious anemia. Gastrectomy patients, the malabsorption states, diffuse intestinal disease like lymphoma, systemic sclerosis, ileal resections, then there is a fist-tapeworm manifestations, and bacterial overgrowth in blind loop and the diverticuli bowel. Folic acid, again same, because of decreased intake due to the diet, alcoholism, and infancy. Absorption is impaired in malabsorption and intrinsic intestinal diseases. There may be an increased loss due to the hemodialysis and increased requirement physiologically in case of pregnancy, the infant, and some cancers also. And if it is a utilization is impaired, the folic acid antagonist. The vitamin B12 and folic acid unresponsiveness in because some metabolic inhibitor drugs like methotrexate, then there is anemia. The dietary source for B12 is it's a basically compound organism known as a cobalamin, and the routinely it is dependent on the diet only in the normal conditions in human being. The microorganisms are the ultimate origin of this cobalamin in the food chain. Routinely, it requires 2 to 3 microgram per day. These are the vitamin B12 foods where you can see the mainly the animal origin. And these are the Vegetarian origin, where we have to fortify the cereals, the unsweetened soya milk, the low fat milk, Swiss cheese, eggs, the tofu, low fat yogurt, and many more. So among all the vitamins, we know that few are the water soluble, few are the fat soluble. So B12 is a water soluble vitamin B12 known as a cobalamin. It resistant to cooking and boiling, synthesized by the gut flora. Uh, it present in foods which derives mainly from the animal products. Deficiency virtually never caused by inadequate intake except in vegetarians who avoid milk and the eggs. The liver can store B12 for approximately 3 years. So mind it, 3 years. Means the B12 deficiency, if somebody is coming, then it means he or she is having inadequate dietary intake since last 3-4 years. This is the normal B12 requirement. I told you that 2.4 in adult, pregnancy slightly increased 2.6 and lactation 2.8 microgram per day. B12 biochemical function is only of two. One, the methylcobalamin, which is essential cofactor in conversion of homocysteine to the methionine by the methionine synthesis. Another biochemical reaction that depends on B12 is the isomerization of MMA to the succinyl coenzyme A, which is again requires this adenosylcobalamin, which is a prosthetic group on the enzyme known as MMA mutase. This is the picture. These two biochemical reactions in the body by the B12. First, we need B12 and folate both from homocysteine to the methionine via the enzyme methionine synthesis. And the second one is the MMA coenzyme to the succinyl coenzyme. Here you can see the only B12 we need, not the folate, but homocysteine to methionine, we need both the B12 and the folate enzyme. Come to the folate, it is vitamin B9, and this is the top 10 foods which are highest in vitamin B12, including your green soybeans, the asparagus, broccoli, the mangoes, sweet corns, lentils, spinach, avocado, lettuce, and the oranges. This serum folate is very sensitive for the dietary intake. Even a single folate-rich meal, which can normalize in a patient with a true folate deficiency, whereas anorexia, alcohol, and anticonvulsant therapy can reduce in the absence of megaloblastosis. That is the reason these red cell folate levels are more accurate indicator of folate stores and the tissue folate deficiency. More than 4 nanogram is normal. From 2 to 4, it is a borderline, and below 2 nanogram per ml is consistent with the folate deficiency. Values may be slightly higher in the first 6 months of the life. This is from the previous slide where I was told you that the MMA and the homocysteine is normal, then there is a no deficiency of both B12 and the folate. If both MMA and the homocysteine are elevated, then deficiency of vitamin B12. But it does not eliminate the possibility of folate deficiency. So if both are raised, then we should go for the levels of homocysteine only elevated, no MMA raised, then there is a no deficiency of B12. Basically, the folate in RBCs, this is a tissue folate levels. So the RBC folate will provide the more information regarding the status of folate over the lifetime of RBC, which is similarly like HbA1c once we are seeing in a diabetic patient. You know that if we want to see the HbA1c, then it will see the preceding last 2-3 months of your sugar control. So same here in the RBC folate, that is the surrogate for the tissue folate levels. Something about the folate trapping. What is folate trapping? Basically, the impaired DNA synthesis in vitamin B12 deficiency is due to the reduced availability of tetrahydrofolate, that is FH4. Why there is a reduced availability of this tetrahydrofolate? Because it is trapped as a pentavalent, the N5-methyl tetrahydrofolate. And this again further exacerbated by an internal folate deficiency caused by failure to synthesize the metabolically active polyglutamylated forms. And this step is required for the vitamin B12 deficiency in the synthesis of methionine, which contributes to something biochemical reaction where typically carbon group needed for the metabolic reactions, which create folate polyglutamate. This is a typical trapping of tetrahydrofolate. Here you can see that this is a methionine synthesis which converts with the help of this tetrahydrofolate to the DNA. So this tetrahydrofolate here you can see it is trapped in the N5-methyl tetrahydrofolate. This is association between all three, the B12, folate, and the homocysteine level, where you can see that here the nucleic acid synthesis, in this side there is a methyl reactions. The methionine will convert into the homocysteine with the help of vitamin B12, and here the folate with the help of 5,10-methyl tetrahydrofolate converts the nucleic acid synthesis. This is again DNA synthesis with the same mechanism. The tetrahydrofolate, this dihydrofolate converts into tetrahydrofolate, and with help of the methyl B12, this tetra converts into the methyl tetrahydrofolate. I just told you that the one thing, the anti-metabolite factor, like here this methotrexate can block from dihydrofolate to the tetrahydrofolate. So again, patient may come with the megaloblastic anemia. Practically, the B12 and folate, they affect all dividing cells. If we talk about in the blood, then it affects all the three lineages of cells, RBC, the WBC, and the platelets. And it also decreases the survival rate of RBCs. The sign and symptoms, the subjective symptoms are fatigue, weight loss, the GI symptoms, neurological complaints, maybe paresthesias, difficult walking, ataxia. The objective findings will be there that pallor and jaundice. The jaundice is something lemon yellow type. Then there is a loss of papilla of tongue, the beefy red tongue. Neurological deficit in form of decreased position and decreased vibration sense, along with the rhombox may be positive, or spastic paraparesis you may find in these type of patients. Some dementia and depression also will be because of this B12, and other associated conditions like vitiligo and thyroid disease may be present in these patients. In folic acid particularly, the fatigue will be there, gray hair, the mouth sores, swollen tongue, forgetfulness, concentration will be low, appetite will be decreased, depression. These all are the symptoms. This is the measure where you can find in the children who are mothers having a folate deficiency, then there will be a neural tube defects also and poor growth in that child. This is classical glossitis, the beefy tongue, the loss of papilla, and this is a lemon yellow pallorness. This is the vitiligo, and here the neurological deficit in the form of subacute combined degeneration. Patient will complain of the gait disturbances. Causes of congenital vitamin B12 deficiency and folic acid. The B12 deficiency, these four causes where the deficiency of the adenosyl cobalamin enzymes, the methylmalonyl coenzyme mutase deficiency, methylcobalamin, and the combined both methyl and the adenosyl cobalamin. And these are the five causes of congenital folic acid deficiency, mostly because of the enzymes which are needed in the formation of DNA synthesis. Now, how we should go to treat these patients? So, in medicine, we know everything starts from the history taking. So, history taking, then physical findings, lab investigation, and then the treatment. So, how we should take the history? We should always ask the dietary history. Very important, because we have seen that the B12 is basically animal origin. So we have to ask whether they are the vegetarian or non-vegetarian, and method of cooking. Goat's milk feeding, definitely in a newborn child or in a infants, we should ask about the goat's milk because they don't have the folate in goat milk. So they may present with the folate and B12 deficiency. Maternal vitamin B12 and folate deficiency, the history of OBS and gynae, prematurity, the fetal growth retardation, loss, Another siblings with the same complaints, the bowel habit alteration, surgical history. Surgical history is very important because in a patient of gastrectomy, you may find the megaloblastic anemia. And drug history, of course, to find out the anti-metabolite drugs. After taking the history, just go for the investigations. We'll see the CBC, we find the anemia. Then most important is the peripheral blood film. What you will find in PBF, there is hypersegmented neutrophils, maybe a oval macrocyte along with the teardrop cells, basophilic stippling, the H-shaped bodies and the cabotin. So here you can see these are the teardrop cells, these are the oval macrocytes, and here you can see the multi-lobed or the hypersegmented neutrophils, classical for the B12, megaloblastic anemia. These are the HJ bodies where the you can see the NC. This is the NC dyschrony or the nuclear cytoplasmic. These are the basophilic stingling, and here this is the Cabot ring. These all are in the peripheral blood film. In bone marrow, where in a severe megaloblastic anemia, here you can see that it become a hypercellular. And the cells, you can see these are the normal cells. These are the larger than the normoblast, and they increase in number also with the multiple lobulated nuclei. Okay. Then they are the giant cells, and these are metamyelocytes, which are hyperpolypoid in characteristics. So this is particularly seen in bone marrow and megaloblastic anemia. I told you that there will be a ME ratio reduce or reverse, hypercellular marrow with ER, hyperplasia, the giant metamyelocyte and band cells. Then the particular B12 levels and the folate levels. The B12 levels will be almost low, less than 80 picogram per ml. Then the red cell folate levels and in serum, they will be low. The homocysteine levels will be increased in both B12 and the folate deficiency, while the methylmalonic acid increase in serum and urine in only B12 deficiency, but not in the folate deficiency. So the methylmalonic acid is more specific for B12 deficiency rather than the folate deficiency. We can find out in the serum and urine LDH in case of megaloblastic anemia. You will find the LDH is elevated, suggestive of increased turn of cells in the marrow due to ineffective erythropoiesis. And measurement of intrinsic factor and urinary proteins, they can detect some syndrome which is known as a Imerslund-Grasbeck syndrome. Orotic acid also excrete in the urine, and the Schilling test and Figlu test. Then again, this is an enzyme, FFF4 enzyme, which detects in the serum, but now these are obsolete. The Schilling test, although it is obsolete, it is having a two steps where we give the oral radiolabeled cobalamin after the 1 hour, then 10% vitamin D B12 radiolabeled in the urine. If it is C, the more than 10%, then positive. Then again with the IF factor radiolabeled. If IF is less than 10%, then there may be a malabsorption because of bacterial overgrowth or pancreatic enzyme deficiency. These are the two steps where in first and second step. In first step, usually we give radiolabeled vitamin B12 1 gram orally after 2 hours, then IM dose intramuscular, which is unlabeled vitamin B12 to saturate the transcobalamin site 1 and 2. Radioactivity is measured in subsequently next 24 hours urinary sample, which is expressed as a percentage of total oral dose. Normally, the more than 7% of oral dose is excreted in the urine. If it is less than the normal excreted, it indicates that there is a impaired absorption, and which is due to the lack of either IF, intrinsic factor, or the small intestinal malabsorption. In second part, basically the patient is again giving the radiolabeled B12 along with the intrinsic factor. So if excretion again normal, then there is a deficiency of intrinsic factor And if it below normal, then there is a defective absorption in the small intestine. But this is now obsolete. This is an interpretation, part one. Then there is a dietary deficiency, part one normal. And part one, only part one abnormal, while the part second is normal, then it is a pernicious anemia or gastrectomy. If both are abnormal, then malabsorption in the small intestine of the Schilling's test. Now come to the last part, the management of B12 deficiency. Daily dose is about 25 to 100 microgram, which is used to start the therapy. Monthly IM injections in dose of 200 to 1000 microgram, which is started as a maintenance therapy. And they should be given intramuscular of cyanocobalamin or oral vitamin B12 therapy. The conventional therapy with the 1000 microgram daily for 1 week, then 100 for 1 month weekly. And then there after every month, the 100 microgram. This is believed to replete sustained body cobalamin stores. How we will check the response after the treatment? By giving a single injection of your cyanocobalamin. The disappearance of megaloblastoid changes in bone marrow is looked in the next 48 hours, means 2 days, besides two of the following, in order to call the test positive. There will be increase in reticulocyte count in 1 week, then correction of neutropenia and thrombocytopenia in next 2 weeks. Oral reticulocytosis subside MCV is decreased by 5 femtoliter. Like if it is a 105 or it is a 110, then after the giving a IM injection, then the MCV will be decreased. Then plasma MMA and the homocysteine in next 2 weeks. Anemia will be covered in next 2 to 4 weeks. So this is the time when the improvement in abnormalities. So expected time in your reticulocyte count and homocysteine within 1 week. Neurological symptoms will be subside between the 6 week to 3 months, and anemia, leukopenia, all MCV thrombocytopenia in the next 2 months. This is the next. If folic acid deficiency, then again treatment with the folate, correction, the underlying causative disorders. They are typically treated with the oral folic acid 1 to 5 milligram per day. We know that this is a more than the recommended daily diet allowance, which is 400 microgram per day, but they allowed adequate repletion even if there is a malabsorption. So before folic acid is given, it is necessary to exclude the vitamin B12 deficiency. To correct the cause of deficiency, we have to improve the diet, gluten-free diet in celiac disease cases, treatment of inflammatory disease like Crohn's and tuberculosis. In other situations, advisable to continue the folic acid to prevent the recurrence. Here also, after giving the folate, the response bone marrow revert in within 24 hours. It starts feeling well in days. Retex counts come to the normal within a 1 week, and hemoglobin starts rising after 1 to 2 weeks. And total normalization of hemoglobin within the next 3 months. And the peripheral smell become normal after 1 to 2 months, as old macrocytic carbocytes, the RBCs, will persist till their life. We know that RBC life is around 90 to 120 days. So that is why the peripheral smear will become normal after this period. Intravenous folic acid indications, those who cannot take the oral medication, or if there is a severe or symptomatic anemia, and in partially reverse some form of hematological abnormalities like B12 deficiency. The administration of folic acid to an individual with vitamin B12 can potentially mask untreated vitamin B12 deficiency or even worsen the neurological complications. So because this, we should test vitamin B12 deficiency, which is appropriate in certain patients being treated with the folic acid. Prophylaxis 5 to 10 microgram for nutritional causes and 1000 microgram per day for patients who are having a malabsorption. And we should give the prophylaxis in some infants who are on the specialized diets. We should give the premature infants and infant of mothers with the pernicious anemia, children of mothers with nutritional cobalamin deficiency, and patients who already undergone the total gastrectomy, and the vegetarian patients, prophylaxis of this B12 should be given. And folic acid prophylaxis should also be given to all women from the moment they begin trying to conceive until 12 weeks of gestation. They should take folic acid supplementation to prevent the NTDs, neural tooth defect, pregnancy, lactation, premature infants, some hemolytic anemias or hyperproliferative hematological states, patients with RA or psoriasis, a patient on the anti-epileptic, and the patients with ulcerative colitis. Something about the megaloblastic anemia, which appears that, but they are not truly. So the manifestation, we have seen that vision problem, memory loss, pin and needle sensation, peripheral neuropathy, and ataxia. These are the neurological manifestation of megaloblastic anemia. Hematological manifestations are the thrombocytopenia, anemia, pallor, weakness, shortness of breath, fatigue, neutropenia, infections, and the bleeding tendency. So, what conditions? They are not megaloblastic, but they mimic the manifestation of megaloblastic anemia. These are the Leschnian syndrome. It is a mental retardation condition with self-mutilation and choreoathetosis present. And it is because there is a impaired purine synthesis due to the lack of hypoxanthine phosphoribosyl transferase enzyme. And some patient may have a megaloblastic anemia. Treatment, they respond well to the adenine therapy. Then the second syndrome is the Wolfram syndrome, where thiamine responsive anemia in Dedmod syndrome. What is Dedmod? It is a diabetes insipidus, mellitus, optic atrophy, and deafness. And hereditary orotic aciduria. These were the neurological symptoms which resemble the megaloblastic. Now the hematological resemblance, the myelodysplastic syndromes, again they mimic malignant conditions, cytopenias with severe megaloblastic finding in the bone marrow. They overlap with the neoplastic process of low-grade MDS or acute myeloid leukemias. Diagnosis includes the excess blast and erythroid predominance as well as pure erythroid leukemia. These are the dysplastic features where we can see the hyposegmentation or the hypogranulation of the granulocytes. There is a hypolobation or small forms of megakaryocytes and increased blast cells. And in the last, is B12 deficiency vertically transmitted? Yes. The answer is infantile tremor syndrome. And what it is? This is a self-limiting conditions where the pallor, the developmental delay regression, skin pigmentation, brown skinty scalp hair, hypotonia. Tremors are coarse in nature, decrease and disappeared in sleep and resolve within 4 to 6 weeks in its natural course. This infantile tremor syndrome occurs exclusively in breastfed infants of strictly vegetarian mothers, and as a result, these are the patients predisposed to the vitamin B12 and deficiency. Clinically, they are similar with the vitamin B12 deficiency of infants, and it follows the infant with B12 deficiency can present with predominantly hematological, the neurological manifestation, and they may have a pure neurological or both in combination in presentation. Treatment of ITS, the B12 if low, then we should give the supplementation, and along the B12 and the blood transfusions, vitamins and minerals, we should give the propranolol till the tremor decrease in intensity and general condition of the patient is better. So thank you everyone for your patience hearing.
Wow, Dariya, Dr. Dariya, this was a wonderful lecture. And we have Dr. Sudhir Mehta, sir, the brain behind this whole class. Dr. Mehta, sir, your comments on megaloblastic anemia. Dr. Mehta, sir, requested to please unmute yourself. Anandji, please unmute Professor Sudhir Mehta.
Yeah.
Yeah.
Yeah, Dr. Dariya, it was a delightful lecture, and you had given a comprehensive presentation of megaloblastic anemia, and especially you have touched the dietary part and the management, as well as the various manifestations, including atypical manifestations. Dr. Dariya, I think you have few questions in the chat box.
Yes, sir. Mm.
Yeah, Dr. Dariya, I'll help you with the questions. Am I audible?
Yes, sir.
Okay, yeah.
Dr. Deepu Rajan asks, in a proven vitamin B12 deficient patient, how long should supplementation be given?
In a vitamin B12 deficient patient, I shows in my slides also. We should start with the daily dose injections with the vitamin B12, then weekly, then monthly. And this is the biggest thing we use in our clinical practice. That is the mistake. Because once we have given the B12, then next 1 month or 2 month, patient will be all right. His hemoglobin will improve and he is not coming next to you. He will end up in the emergency after 3-4 years again with the same B12 deficiency. So we should always advise the patient to take the vitamin B12 supplement lifelong in cases of B12 deficiency. And how we should give it? I think after the 1 year, the 3 month, every 3 months, if we advise taking every yearly a single injection of B12, because we know it is a very stores in your cells for at least 3 months, 3 years. I told you in that also. So once if you are giving a single injection every year, patient will never come into the B12 deficiency.
Okay, so that was right. There is another question. How can peripheral blood smear differentiate megaloblastic anemia from other cause of macrocytosis?
In peripheral blood film, we know that macrocytes can be at two reasons. One is the megaloblastic, another one is the non-megaloblastic. So if there is a hypersegmented neutrophils are there, there is a erythroid precursor cells, there is a metamylocytes, and all the things will be present along with the your biochemistry B12 deficiency. Then it is of your megaloblastic anemia. If it is not, then other causes may be due to that peripheral blood film.
Okay. And which route would you recommend as a good route of supplementation, IV or oral? So this question is for supplement. Would you recommend IV vitamin B12 or oral vitamin B12?
The preferred route to supplement is IV, because if a patient is having a malabsorption syndrome, or patient is having a gastrectomy, or patient is having some problem in Crohn's or in ulcerative colitis or ileitis, or so the preferred route should be the always IV. Nowadays we are seeing that there is a preparations coming in the market, and they are giving the nasal sprays also. They
Yes.
nasal spray is available. Then there are the sublingual preparations are also available in the market. But I'll prefer for the good supplement, the IV route is the best route.
Dr. Neha asks, megaloblastic anemia is always associated with atherosclerosis, as homocysteine level is high in both vitamin B12 and folate deficient. So, Neha, what is your question exactly? The question is not very clear. So
Actually, what I think Dr. Amit, she wants to know that is megaloblastic anemia always associated with atherosclerosis?
right.
Yeah,
This was
I think
asked.
that atherosclerosis has different numerous pathophysiologic mechanisms, and serum high level of serum homocysteine is just one of the associates
Anyways,
of atherosclerosis. And So it's not that megaloblastic is always associated with atherosclerotic process.
Right, sir. Now other questions are also there. Early markers of neurological damage in vitamin B12 deficiency. Can they be used to assess treatment efficacy? So what would be your early marker of neurological damage?
Clinical would be, of course, the earliest would be loss of vibration sense.
Paresthesias and symptoms would be paresthesias and vague weakness. But when we elicit a loss of vibration sense, that should be the earliest marker, right, sir?
Yes, right.
Right. So they can also be used to assess treatment efficacy also in the clinical parameters. But then Dr. Dariya has already defined the course of improvement. So that would be a true guide while you manage your vitamin B12 deficiency. Dr. Dariya, please. Dr. Deepu again asks, folic acid can be used, is usually used in pregnancy to prevent precipitation of vitamin B12 deficiency, vitamin B12 neuropathy. Should vitamin B12 also be supplemented in pregnancy along with folic acid? Hello.
I think Dr. Dariya.
Hello.
Sorry, sir. Actually, I joined from the mobile because of some call is disconnected.
Vitamin B12 is a long, it has a long store. So pregnancy, unless you have evidence of vitamin B12 deficiency, there's no point prophylactically giving vitamin B12 in prophylaxis. So am I correct, Dr. Mathia, sir? Can folic acid be used in place of folinic acid in methotrexate deficiency? Toxicity.
Thing is, of course, folinic acid is a more active metabolite of folic acid. So one can always also use folic acid simply to prevent methotrexate toxicity.
Are there any more questions?
I think Dariya, just one more comment I would like to make. Metformin, prolonged use of metformin can cause B12 deficiency. So you just have to look for B12 deficiencies in diabetics on high dose of metformin up to 2 grams per day. And then important thing is the betel nuts, suparis, can cause B12 depletion. So in the history, it's very important that if patient taking gutka or supari, whatever the betel nut is there, which is one of the component of these various gutkas and everything, I think that is equally important in our country.
Right, sir. So I would also
definitely, sir.
I would also like to share my experience that many patients, especially of a particular community who are vegetarians and who also have the habit of taking lots of pan masala and gutkas, they
Yes.
take these betel nuts. They present with pancytopenia and panicking about aplastic anemia, and they have been found to be having vitamin B12 deficiency. So
Yes, you're right.
So pancytopenia may not always be a reflection of absolute aplastic anemia. It would rather be a manifestation of vitamin B12 deficiency. As rightly said by Dr. Mehta, betel nuts can cause vitamin B12 deficiency also.
Tiwari sir has joined.
Yeah, welcome, Dr. Tiwari sir, the Dean of ICP, the person who is behind this ICP short certificate course. Welcome, sir. Your comment on this.
Well, I haven't heard the whole thing, just joined. But yes, pancytopenia is seen in B12 deficiency. That is sure. But I don't know the things behind the whole episode, what is going on.
So the class has been wonderful, wonderfully executed by Dr. Dariya, and we would like to have your blessings on in this ICP certificate course.
Well, I am always here to give blessing for this course. Actually, this is my brainchild, and this is a very good idea for students as well as for young doctors too, because it is giving a real teaching, the teaching which we don't get in CMEs, but here it is the whole time teaching, which is very much beneficial for all. And my blessings are with you all. Thank you very much.
Thank you, sir. It was nice to have you on this platform again. And we also have Dr. Sanjay Kumar with us. Dr. Sanjay, sir. Dr. Sanjay is the Joint Secretary of ICP from Dean's Place, and we request his presence here. He was just with us a few moments from here now. Okay, let's see some more questions. Again, the same question is for replacement of vitamin B12. IM route is better than IV as vitamin B12 is water soluble. It may be excreted in urine, or both are same. So Dr. DS Tawar contradicts with IV route. Hello.
Well, there is always a risk of hypersensitivity and anaphylactic type of reaction with any IV injection. So that may be here as well. Hello.
Hello. Hello.
Dr. Amit, I think you are disconnected. There's another question. When to recheck B12 levels after replacement? Dr. Dariya?
Yes, sir.
There's a question in the box. When to recheck B12 levels after replacement?
So if we are giving as per protocol of vitamin B12, I told you that you will see the vitamin B12 completely normalized within the 3 months or the 12 weeks. So once if it is a normalized, then if you are giving as per protocol every 3 months the IM injection, then no need to go for a vitamin B12 recheck.
There's another
Dr.
question. Dr. Mehta, sir, I'm connected.
Yes.
I was getting calls on this phone, so I get my voice gets muted. There's another question. Is in a patient with macrocytic anemia and neurological symptoms, if both serum between B12 and folate levels are normal, what alternative diagnostic approaches would you consider and how would you manage the case? So,
Mehta, sir.
in the presence of B12 and folate being normal, would you expect macrocytic anemia? And if macrocytic anemia and neurological symptoms coexist, what alternative diagnosis would you think of?
I think very it's important that we should not depend on serum folate level. Now, this is even affected by what you eat at night also. Because folate, green leafy vegetables are rich in folic acid. So more important is RBC folate. So if you have a high index of suspicion of megaloblastic anemia and B12 is normal, I think one should go for RBC folate. That would give you the true picture of the folate deficiency in the body.
Dr. Dariya has already defined on the importance of RBC folate estimation, and he also correlated with this with HbA1c of diabetes. So RBC folate would be a true indicator of vitamin folic acid levels, right, sir?
Yeah, and then you have other conditions like alcoholism can have neurological symptoms with macrocytic anemia. So there are other non-nutritional causes of where you have a macrocytic anemia along with neurological deficiency. And classical would be alcoholism.
And sir, as already defined by you, that diabetes with high dose of metformin can cause megaloblastic anemia. Diabetes itself can cause peripheral neuropathies of the
Yes.
same type. So diabetes can also have a similar kind of presentation. So if you have a suspicion, you can always rule out diabetes in those situations. No, diabetes cannot itself cause megaloblastic anemia. Diabetes can cause peripheral neuropathies. Longer neurons get afflicted with diabetic neuropathy earlier, and they have similar type of presentations as megaloblastic anemia causing posterior column disease. So if you're finding a patient of megaloblastic anemia with normal B12 and still having posterior column tract signs, think of diabetes. Sorry. That was the point which I was trying to make. Diabetes does not cause megaloblastic anemia.
Yes, diabetes itself does not cause the megaloblastic anemia, but symptoms like that megaloblastic anemia just because of the polyneuropathy. There is a symmetrical polyneuropathy in a diabetic patient. That patient come with the ataxia, patient come with the numbness, patient come with the all symptoms. But itself, it never causes. The only thing in diabetes, if you are giving a metformin in higher doses, then you may have a megaloblastic anemia, but not per se diabetes.
Hello.
Yes, sir.
Am I audible?
Yes, sir, audible.
Sir, I think most of the questions have been answered, and this session has been bang on time. Can we conclude, Dr. Tiwari, sir?
Yes, you can.
Dr. Mehta has called me immediately now that his connections have become faulty. So, with permission of Dr. Tiwari and Dr. Mehta, and great thanks to Dr. Dariya, I would conclude today's session, and I would thank everyone for joining today's ICP short certificate course on hematology by Dr. S.S. Dariya, mentored by Dr. Sudhir Mehta and guided by Dr. Kamlesh Tiwari, Dean ICP. Thank you everyone for joining. Meet you the next Tuesday at 2:30 p.m. Same time. Next time, we'd be having Dr. Avinash as one of the course class teacher for that. So seeing you, hope to see you all in the next class and wishing you all a very happy Holi. Thank you very much.
Thank you so much,
Thank
sir.
you very much.
Thank you, everybody. Thank you, sir. Thank you.
Thank you.